Good morning, dear patient, dear colleague, and dear friend. Today we will have the second lecture on education in endometriosis, and it will be really my pleasure to talk a little bit something we heard everywhere, and is very important, is what we call the nerve-sparing surgery in endometriosis. So, let's start with endometriosis. So, to understand why for 25, 30 years, I started to develop the technique of nerve-sparing surgery in endometrial surgery is because I'm an oncologist. And as an oncologist for 30 years, when you perform surgery, for example, for cervical cancer, it was usual that about 30% of the patients were not able to empty the bladder after the surgery and had to use a bladder catheter for the rest of her life. And at that time, we were thinking, why? Why? Because when you are performing surgery for cervical cancer or another gynecological pelvic cancer, the nerves are not usually involved in the pathology. They are not the cause of the cancer and usually are not involved by the cancer. The nerves are really at the pelvic side wall. And when you have a gynecologic cancer like cervical cancer that reach the pelvic side wall, there is no indication for surgery. In such a situation, you have to do radiochemotherapy. So the first thought was, why to not try to preserve the nerve in order to reduce the postoperative morbidity, in order to enable the patient to be able to empty the bladder, the rectum, and to have still sexuality after the surgery. So the idea was try to preserve the nerve, and for that you have to identify the nerve during the surgery to see where you will find the nerve. And that became very much easy once we introduced for 30 years the laparoscopic surgery in gynecology oncology, because laparoscopy is like a microscope. You will see the small nerve from 1 millimeter or even less on a beam screen, like something from 1 or 2 centimeters. So if you're able to better see and recognize the nerve, it will be much more easier to preserve the nerve. And it's exactly what we perform we did in oncology surgery. And from one day to the next, from about 30-40% of the patient not able to empty the bladder after the procedure, we came in the area of nerve sparing technique with patient more or less more than 95% of the patient were able to empty the bladder after the procedure, were able to empty the rectum and had still a sexuality and feeling in the vulva and the vagina. And then the next step was to say, why not to do the same in endometrial surgery, which is even more tricky because in oncology, we are dealing with patients maybe not 20, maybe 30, 40. And usually these patients have no further desired pregnancy. So you will remove the uterus. In endometriosis, contrary, we are dealing with very young patients who have further desired pregnancy, who want to have a preserved sexuality and of course pelvic organ function. So it's maybe not more important than in oncology patient, but it's important as well. And we're not talking from an oncological disease. So to understand what is nerve sparing, we have to understand what is or which are the function of the pelvic nerves. And you will have the same function for the bladder, for the rectum, and partially for the sexual organ. But let's talk about the urinary function. So the normal bladder has three functions. One, to store urine, and the normal bladder capacity is more or less 300 to 500 milliliter. So more 300 in woman, more 500 in men. Then the organ, the bladder, and first of all the sphincter of the urethra have to control the urine and to avoid leakage, to avoid urinary incontinence. And of course, the third function is the emptying function. So the bladder has to be able to contract. The bladder is a white muscle. So the bladder has to be able to contract, while at the same point in time, the urethra will get open, and that is a way why the bladder is able to empty. And for that, we have several nerves in the pelvis. You have the nerve of the feeling. These are usually the vegetative nerve, or maybe you heard the word previously, hypogastric nerve or hypogastric plexus. These nerves are for the feeling of the bladder. These nerves are giving to the brain the information, now it's time to go on the toilet. They are the hypogastric nerve, and that is one of the first mistake I have to point out. Actually, in a lot of publication and lecture all over the world, you will hear we preserve the inferior hypogastric nerve in order to preserve the voiding function of the bladder. And that is really a big mistake. The inferior hypogastric nerve and plexus are involved in the feeling of the bladder, the feeling of the vagina and the rectum, but not in the voiding function. The voiding function, the nerve in charge of the voiding function, are what we call the parasympathetic nerve or the pelvic splanchnic nerve, which are located deep within the pelvic cavity and which innerve from the sacral plexus. And then there is a third nerve, also emerging from the sacral plexus, is the pudendal nerve. And the pudendal nerve is in charge of the control of the external sphincter. That means for the urinary incontinence, the urethra is controlled by by two kind of nerves, the vegetative nerve, because there are two sphincter, one proximal and one distal, or internal, external. The internal sphincter is controlled by the vegetative nerve system, the hypogastric plexus, and the external by the pudendal nerve. So once again, if the hypogastric nerve controls the internal sphincter, damage of the hypogastric nerve will more induce an incontinence than difficulty for voiding. So if in the situation of endometriosis, you can find two situations. One, you have an irritation of the nerve. And when you have an irritation of the feeling nerve, the vegetative nerve, which are contained is what we call the sacrouterine ligament, the patient will get much more often the information in the brain, I have to go. And that is the reason why, for example, patients affected by endometriosis have to go much more often on the toilet to empty the bladder, to empty the rectum. And that is the reason why in a lot of patients, we are saying, oh, you have one urinary infection again. Every month you have infection. Yeah, very often they are not infection, but an irritation of the feeling nerve of the bladder that brings the information brain, you have to go. But it's not an overactive bladder. That means it's not the bladder that contract much too often, but the feeling nerve. That means it makes no sense in such a situation either to treat a bladder infection if you have not the proof of a large amount of bacteria within the urine. And secondly, it makes no sense to try to relax the bladder by with a prescription of anticholinergic or Botox or whatever. So now you have also the risk of the irritation of the voiding nerve of the bladder. Then we're not talking from overactive bladder, but it's quite urgency. So patients have to go quite frequently and urgently to the toilet to empty. So now introduction about endometriosis. We all know endometriosis is a very common condition that affects millions of patients over the world. Probably when we are talking 10% of patients are affected by endometriosis, it's wrong. It's much more, but not all kind of endometriosis require surgery or need really a surgery. Because not all endometriosis will become a deep endometriosis, not all endometriosis will induce huge bleeding, and not all endometriosis are cause for infertility. So the deep infiltrating endometriosis is a special form of endometriosis because it's a benign tumor form of endometriosis, usually that develop from the cervix and will affect first, usually, the sacrouterine ligament. That means this kind of endometriosis will affect the pelvic nerve, and that is the reason why endometriosis are painfully. And if you saw my last education in endometriosis on the LUNA technique, I mentioned that one idea is to say if endometriosis affects the sacrouterine ligament and induces an irritation of the pelvic nerve, one simple way to block the transport of the information pain to the brain is to cut the nerve. It's what we call the LUNA technique. But in view of what I'm talking here, it's clear that if you want to perform a nerve sparing technique, you cannot cut the nerve. So, what are the bladder dysfunction in patients affected by endometriosis? So, many of the patient will always only have an irritation of the nerve. So, once again, patient will have to go much more often on the toilet, maybe sometimes a little bit urinary incontinence. So they will get very often the diagnosis urinary infection, and sometimes even a diagnosis which is not appropriate in endometriosis patient, the diagnosis of interstitial cystitis. But if patients have a huge deep endometriosis that affect and destroy the nerve, then the patient can develop difficulty for emptying the bladder, chronic constipation with difficulty to empty the rectum, and a loss of sexual function. But it's clear that the main cause in endometriosis patient for loss of the pelvic nerve is not the endometriosis itself, but the surgery, especially in deep infiltrating endometriosis. And that is the reason why for 30 years I developed the nerve sparing technique. And of course, the patient will have the same issue with the rectum, with constipation, bowel irritability, and so on, and for the sexual function as well. So on this picture, you see a photo, is the first photo in the world on the parasympathetic pelvic splanchnic nerve. This photo, I made this photo for more or less 30 years, and that is the first time we were able to recognize by laparoscopy the pelvic splanchnic nerve. And you see, they are very, very small nerve, very thin nerve. They are maybe 0.1 or 0.2 millimeters. They emerge from the sacral plexus, which is located at the pelvic side wall. Here, for example, number 2, it's a sacral nerve root. And here in 1, you have the small nerve. We have more or less 5, 6, 7 small nerves on each side. That means the pelvic organ function depend from maybe 2 hands of very small nerve. 2 hands, 5, 6, 7 on the left, 5, 6, 7 on the right. And this photo, I did it during a oncological surgery. Once again, in oncology, normally at the pelvic side wall, there is no tumor, otherwise there is no indication for surgery. So it will be easy to recognize the nerve and to spare the nerve. Now, in endometriosis, it's a little bit more difficult, and for 25 years, 30 years, more or less, this is the same in the 90s, end of the 90s, we had on International Congress a lot of discussion, for example, especially for rectum resection, because the idea was performable resection will induce bladder atonia, rectum atonia. But over the last 25 years, as a neuropelveologist, I saw a lot of patients coming in my office with bladder atonia, so they are not able to empty the bladder, and the same for the rectum, after endometriosis surgery. And the idea was to check out, to find out, is really due to the surgery. And by the through, what we found out in this publication I made for many years is that the main issue was not the cutting of the nerves, the pelvic splanchnic nerves on both sides, but what we call neurogenic bladder. You remember I explained that when you remove endometriosis, of course, you will have to cut part of the sacroiliac ligament and you will damage. That is normal because you want to resect the endometriose. You will induce damage of the hypogastric nerve and plexus. That means the patient will have less feeling when she has to go on the toilet. And that is the main cause for bladder atonia or the incapability of avoiding the bladder. Why? Because suppose you're a young lady, you're 30 years young, you underwent the surgery, you have much less pain, you want to get pregnant, you will get babies, and then your life is full. You have to work every day. You have a family, you have kids, you have a job. So if you got such a surgery and we resect part of the nerve of the feeling, that means it's no need for you to go every 3 hours on the toilet to pee. If you have no time, if you don't sing on your bladder, it's easy to go once in the morning and maybe the next time in the evening. And in between, you will not lose time to go on the toilet. And that is a big issue because once again, the bladder or the kidney produce more or less in a woman 300-400 milliliters. That is the capacity of the bladder. And the kidney produce more or less 100 milliliters per hour, more or less, depending from what you're drinking. That means every 3-4 hours, your bladder is full. So normally you have to go every 3-4 hours on the toilet to empty your bladder, not over the night because the kidney, the production of urine is decreased. So if you go once in the morning and the next time in the evening, over the day, the bladder will get enlarged, will become bigger and bigger. And after a while, and if you see this data, after 6-7 years, the patient develop what we call an overdilation of the bladder. So the patient, the bladder capacity is not by 300-400 milliliters, that is the normal, but increase over the year to 600-700 milliliters, or even in some patients 1 liter. Means that over the time, due to the overdilation of the bladder, and because the bladder is a muscle, the patient destroyed the muscle of the bladder. So after a while, the patient is able to pee, the sphincter will get open, the nerve on giving the right information, please contract. But if the bladder lost the capability of contraction due to the overdilation of the muscle, the patient will be able to pee, but not to empty the bladder. So suppose the patient go with 600 milliliters on the toilet, she will be maybe able to empty 300 milliliters, but she will keep 300 milliliters in the bladder. And that is one of the problems. If you're not able to empty properly your bladder, over time, you will develop bladder infection. And even more when you will become postmenopausal, because then due to the lack of estrogen, the risk of bladder infection will increase. Exactly the same if, as an endometriosis patient, you're getting progesterone and analoga LH-RH over years. It will increase the risk of a bladder infection as well. So, in summary, I would like to give you some very important message. The first message: empty your bladder at least every 4 hours, even if you don't feel the urge, especially after endometriosis surgery. So if you're not able to remember to go on the toilet, you have an iPhone. So you have to have a bell every 3-4 hours, gling, 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 I have to go on the toilet, even if you don't feel the need to go on the toilet. Secondly, when you're going to your gynecology maybe once a year, you have to control the post-void residual volume. That means your gynecologists have to check the kidney. That is, in my opinion, mandatory in every endometriosis patient. The gynecologists have to perform sonography of the kidney in order to exclude a dilation of the kidney. Secondly, your gynecologists have to send you on the toilet you empty your bladder, and then your gynecologist will check how many residual you have left in the bladder. And the normal is more or less below 50, 70, 80 milliliters. So the most important is that your gynecologist register years after years the residual volume. So suppose you had a surgery and then you are by 100 milliliter residual volume. But from 1 year to the next year, we are always by 100 milliliter. That is fine. You can even empty your bladder with what we call the doppel voiding technique. You go on the toilet, you empty, you don't press, and 10 minutes later, you go a second time. But if your gynecologist said, oh, after the surgery, everything was fine, it was by 50. 1 year later, you're by 70. 1 year later, you're by 80. And then the volume increase over time, then you are in danger. You're in danger to induce an overdilation of the bladder over time. At such a situation, please, go at least every 3 hours on the toilet. Not too often as well. If you go now every hours, your bladder will get smaller, and then you will have really for the rest of your life to go every hour. So the best is more or less 300 or 400 milliliter. And for that, it's easy. Once or twice over the year, when you go on the toilet, you pee in something and you measure your residual volume. The third message, exactly what I mentioned before. You have to check your kidney, because when you have an endometriosis of the bladder or the ureter or the small channel which brings the urine from the kidney to the bladder, because this kind of endometriosis develop over years, you will not feel pain like in kidney stone. You will have back pain, but every patient affected by endometriosis have back pain. So nobody will think it could be an endometriosis of the ureter, which will induce a dilation of the kidney. And over years, once you get a huge dilation of the kidney on both sides, then there is the risk to develop a renal insufficiency, and the treatment then is dialysis. So please, a renal sonography take 10 seconds on each side. It's really not a big job. It's easy to be performed, and it can save your life, or at least your kidney. So now the laparoscopic nerve sparing, how it worked. Once again, I developed this technique in the 2000s, end of the 90s. I introduced what we call the LANN technique, because in order to be able to recognize the nerve and the functionality of the nerve, I brought during laparoscopy the technique of stimulation of the nerve, electrical stimulation of the nerve. That is a technique well known by neurosurgeons. For example, when they are doing thyroid surgery, they have a stimulation of the recurrent nerve to avoid lesion. Or some neurosurgeons, when they are doing brain surgery, the patient are not in deep anesthesia, are awake and play guitar, just for the neurosurgeon to be aware if they are destroying some important area of the brain or not. So this LANN technique protects the patient not from a lesion of the hypogastric plexus of nerve, because when you have a big endometriosis there, you cannot pray there, but a lesion of the pelvic splanchnic nerve, the parasympathetic nerve, which are in charge of the voiding function. So now I want to point out two common misconceptions in nerve sparing technique. The first is to try to dissect the nerve out of endometriosis. So I mentioned previously in oncology, there is no tumor at the level of the nerve. You can identify the nerve, and then you let the nerve free during resection of the uterus, the tumor. In endometriosis, it's not the same, because in endometriosis, suppose you have what we call a parametric endometriosis. So in endometriosis from the cervix that affects the sacrouterine ligament and grow to the pelvic side wall, this kind of endometriosis, deeply infiltrating endometriosis, will completely involve the nerve. And now to say, such a high-skilled surgeon that I will be able to dissect all these small nerves. You remember 5, 6 small nerves less than 0.1, 0.2 millimeters out of this huge endometriosis fibrotic tissue? Forget it. It will never work. So suppose you have a big endometriosis on the left, you have to remove the endometriosis and you will cut the pelvic splanchnic nerve. So nerve sparing technique in endometriosis surgery mean preserve the nerve from the surgeon. And that is a problem because when you have a deep endometriosis, usually or most frequently, the endometriosis will grow on the left. And then nerve sparing will mean don't go on the right. Don't preserve the nerve on the right. Don't touch the nerve. That is nerve sparing. And the second misunderstanding is nerve sparing don't mean dissecting the nerve, because I'm aware that some colleagues try to dissect all the nerve from the pelvic hypogastric plexus down to the pelvis. So you see beautiful video where you see all the nerve at the end of the procedure. That is not nerve sparing. Nerve sparing means you see the nerve and you don't touch the nerve. There is no need to dissect the nerve all the way down to the pelvis. You have to preserve the nerve, to don't touch the nerve. Every dissection of the nerve may induce damage of the nerve, postoperative fibrotic tissue that can even induce secondary damage to the nerve. So once again, nerve sparing don't mean dissecting the nerve. Nerve sparing refers to the identification and preservation of the nerve during surgery, and not dissection of the nerve. We are talking from the autonomous nerve. Huh? We're not talking from endometriosis of the sciatic nerve. So now, once a patient has developed incapability of avoiding the bladder after endometriosis surgery, that is really tricky, because there is no way to find out how many nerves on the right and on the left have been destroyed. And of course, if during a surgery all pelvic splanchnic nerve has been destroyed on both sides, there is no way to help the patient. The patient will have to avoid the bladder 5, 6, 7 times per day with a bladder catheter for the rest of the life. So what we are doing in my center, we are doing a urodynamic testing. During the urodynamics testing, I have the measurement of the pressure inside the bladder. And during this testing, through the vagina or through the rectum, I will bring a small device to bring stimulation, electricity on the nerve. And during this urodynamic testing, when we are bringing electricity on the left, on the right, we check if there is a small reaction of the bladder. So maybe you will see that the pressure in the bladder increase, not enough to be able to empty the bladder for the patient, but you will see, oh, on the right, there is still an answer, or maybe on the left. And then you have to bring electricity on the nerve. You have to increase the activity of the nerve. And for that, that's the reason why I developed the LION procedure for more than 20 years, 25 years. It's like the sacral neuromodulation. You bring one lead electrode connected with a neurostimulator, pacemaker, to bring electricity on the nerve. But if you're doing that from behind, like the interseam therapy, you cannot just implantate one pacemaker, one stimulation lead on one nerve. And the pelvic splanchnic nerve, like you see on this picture, emerged from the sacral nerve root S2, S3, S4. So with the LION procedure, I'm able to bring one lead with multiple stimulation pole tangentially to the sacral nerve root. So with one lead electrode per side, I'm able to stimulate S2, S3, S4, mean all pelvic splanchnic nerve. So in patients with bladder atonia after endometriosis surgery, of course, if the patient has developed an overdilation of the bladder and the capacity is more than 1 liter, make no sense to make a LION procedure. But if the bladder capacity is normal range 3, 4, 500 milliliters, And urodynamic, you found there is some little answer on one or on both sides. Then we do the LION procedure. We bring such kind of lead electrode on the sacral nerve root S2, S3, S4 on both sides. Then we perform, after the surgery, a test stimulation for 2-3 weeks in order to check if the electricity we're bringing to the nerve will be enough to induce such a contraction of the bladder that the bladder is becoming able to empty. Then we connect the both electrode with a rechargeable neurostimulator. And over time, it's not excluded that the patient will recover a normal function of the bladder, and maybe after 10 years, 20 years, maybe we'll be able to remove the pacemaker. But that is something we have to find out over time. So, in summary, endometriosis surgery can affect nerves that control bladder and sexual function. And the first cause of damage of this nerve is not the endometriosis itself, but the surgery, the surgeon. Modern technique like the LANN technique, LANN for laparoscopic neuronavigation, mean to bring electricity on the nerve, to identify the nerve, and then to spare the nerve and not to dissect the nerve during the procedure, can prevent from postoperative bladder, rectal, and sexual dysfunction. The LION procedure is the only procedure that can help patients to recover more or less normal function when the patient develop bladder atonia directly after an endometriosis surgery. And protecting the nerve is the key of your recovery, is the key of the preservation of your pelvic function. So I thank you very much for your attention. And we will see us again for the next lecture, probably focusing on vascular entrapment again with 3 different very important diseases, the thalassemia, the sickle cell disease, and Ehlers-Danlos syndrome. So I hope you enjoy my patient education video and keep healthy. Thank you. Bye-bye. Have a good day.